Good afternoon, everybody, or good morning, wherever you are. Welcome to the second day of the PFIC Network Educational Series. Joining me right now is Dr. Jim Squires of Children's Hospital Pittsburgh. Dr. Kyle Soltis is finishing up a procedure, so he'll join us for the later portion of the webinar. We'll give everybody another minute or so to log in, and then we will get started. Carrie, do you want to go ahead and cue up my slides for me, please?
Yeah.
Thank you. Okay, Carrie, I think we can go ahead and get started. You could take me to the next slide. So just a few things, housekeeping things that we're going to go over real quick. We went over this yesterday. Sorry for the redundancy. We're just going to kind of breeze through for anybody who's new. PFIC Network has put together the PFIC educational series. Our organization does have support from both Mirum and Albareo pharmaceutical companies. And also we're supported by a generous grant from Global Genes, and we're proud members of the Rare Foundation Alliance. A few disclaimers. These sessions were set up to be in both for information and education purposes only. We are not able to give any medical advice. Please consult your doctor if you have any questions specifically related to you or your child. But we do encourage that you use what you learn here for talking points with your doctor if you do have something specific you'd like to talk about. Zoom is not a HIPAA compliant platform. HIPAA is the Health Information Privacy Act. So just be mindful that anything that you say or that you type out, please leave patient identifiers such as name or date of birth or specific disease out of it because it's not protected under that Privacy Act on Zoom. And this session is being recorded that we can use later to post onto our website for further educational purposes, and we may use it as we see fit for promotion via social media, newsletter, etc. I'm going to give a little bit of a background on myself and the PFIC network. The PFIC network was developed with the mission to improve the lives of patients and families affected by PFIC worldwide. Our mission is pillared in education, support, advocacy, and research. Our team represents PFIC parents and patients from all areas of the world. My name is Emily Ventura. I am co-founder and now executive director of the PFIC network. A little bit about me. My daughter has PFIC-2. She was diagnosed back in 2012. She has been through the entire spectrum of PFIC management and treatment. Most recently, she had a liver transplant in 2017, and she's doing quite well. I'm an ICU nurse by trade. However, the recent demands of COVID and taking care of a child who's had a liver transplant has been very challenging. So I've stepped away from the bedside hospital world for the moment, and I'm focusing on building and growing our PFIC community. We work with a fantastic team of physicians that represent institutions from all over the country and across the world. Dr. Jim Squires is one of the physicians that's on our medical advisory board. And our medical advisory board helps us to prioritize and create opportunities that are deemed necessary by the needs of the community. A brief history on who we are and what we've done. So our organization hosts the website pfic.org. Our initial focus was to bring the community together worldwide and provide education and support and awareness. We've done that through things such as our first family conference, which we hosted last year. We've created PFIC Awareness Day, which is coming up. Our second annual PFIC Awareness Day is coming up next week. And we've created peer support programs such as financial assistance programs, mentorship programs, and bereavement programs that people are going to be able to access all over the world. Our current focus is to continue assessing the needs of our community. We're trying to identify and document knowledge and resource gaps all over the world so that we can create meaningful programs for our community abroad. We've done that through our website. We've recently launched our patient self-report registry. We have this virtual meeting series that we're very proud to kick off. And again, we have the PFIC Awareness Day and Hospital Outreach Program that are launching next week. So without further ado, I'll pass it over to Dr. Jim Squires to talk about life after transplant. And shortly after, he will be joined by Dr. Kyle Soltis to talk to us about specific complications related to PFIC. Jim, before you take over, I just want to draw people's attention to this chat box at the bottom of the screen. You can use that to ask questions at any time during the session, and we will have an open Q&A towards the end of each talk. You're up.
All right, let's see if I can get this to work. Let's see, and if I do that, does that look okay?
Looks great.
You see just the big slide, not the notes section or anything?
Correct.
All right, excellent. So guys, thank you again. I just want to thank Emily for the invitation to address the group. I've obviously known Emily since her kind of iteration of PFIC has started up, and I think what she and you all have done has really been amazing for these children and for these rare diseases. And so it is my pleasure to talk to you today. We've switched up the schedule a little bit because, again, my colleague, Dr. Soltis, is in the OR. So I'm going to talk about life after transplant for progressive familial intrahepatic cholestasis diseases. I'm going to try to just kind of go through, I have some slides, but go through them pretty quickly. I think what is generally most beneficial for me during these sessions is kind of the open Q&A and discussion to make sure that kind of we address issues that are important to you. Again, I'll have some slides, but we'll have plenty of time to talk here when the talk is over. So again, I think the challenge was to talk about life after transplant for PFIC, right? But in many ways, life after transplant for PFIC is like life after many things for PFIC. There are some specific challenges that we'll talk about towards the end of the talk, but in most cases, in many cases, transplant for PFIC is similar to transplant for any other hepatocellular disease. So what is transplant? What is kind of the history of transplant, right? So this is Tom Starzl. He was the transplant surgeon originally out in Denver who came here to Pittsburgh and really founded transplant. So he attempted the first liver transplant in 1963 out in Denver. It wasn't a child, a 3-year-old with biliary atresia, which is another very common cholestatic disease in children and the leading indication for liver transplant. Unfortunately, this child died on the table during the operation. 4 years later, he went back at it and he performed what we generally consider to be the first successful liver transplant, again in a child with biliary atresia. That's her picture there, Julie Rodriguez, and that's her 1 year after transplant. We kind of talk about errors of transplant. I think one of the kind of keystones that changed the landscape of transplant, or many of the keystones, kind of come in the form of medications that have been discovered. So in 1980, Tom Starzl and his group introduced an anti-lymphocyte globulin, cyclosporin. And cyclosporin was really one of the first immunosuppressive medications that enabled longer-term transplant survival as an immune suppressive agent controlling the immune system's reaction to these transplanted organs. In 1981, Tom Starzl moved to Pittsburgh. He founded the first pediatric liver transplant center here in 1985 at the Children's Hospital of Pittsburgh. And since that time has been one of the busiest transplant programs in the country. So this is an older picture and not specific to PFIC, but looking at, again, as time has gone on, how we have done as it relates to transplant. And so, again, seeing back in the 1980s, 658 liver transplants, that graph survival there on the left is showing that in about 5 years, only about 50% of livers were still in with their patients. Obviously, as we've gone through the decades, that number has improved. And today, we expect 5-year survival to be north of 90–95%. Indications for transplant have changed over time, but one of the most common ones has always been the metabolic diseases. We generally consider PFIC to be a metabolic disease in that we know what the metabolic defect is. Sometimes PFIC will get grouped into the cholestatic diseases, and so I think depending on what you're reading, you may see those grouped differently. Here we generally consider a metabolic liver disease. Again, this is our experience of transplant for metabolic liver diseases. You see that gray pie piece there of about 11% of our pediatric liver transplant for metabolic diseases have been in PFIC patients, which is, when you look at other large series, pretty similar, pretty analogous, right? So here's a couple from the Italian series and a larger European series. You see 21% and 14% PFIC experiences. Specifically looking just at metabolic diseases, again, a graph similar to the others showing that we're doing more and more transplants for these metabolic diseases, and the outcomes are getting better and better over time. I think, again, we talked yesterday about the different PFICs, and I think the more commonly described now 6 PFICs with their specific protein and genetic defects there on the box. And when you read the literature, there has been transplant experience in every single one of these diseases. In some of the instances, the transplant occurred before the gene defect was known, but in all instances, liver transplant has been offered to children with various defects. So what are some of the general challenges, after transplant, right? So these are kind of, 5 categories that we think of sometimes that we often need to address in patients, and particularly children post-liver transplant. So first is transplant morbidities. And again, this is more, surgical complications, right? The early post-operative period, the delayed wound closure, the ventral hernia repair, needing an exploratory laparotomy to address a surgical complication, hepatic artery thrombosis and intra-abdominal bleeding, pleural effusion, which are very, very common with the need for chest tube placement. Again, my colleague, Dr. Kyle Soltis, talked yesterday about kind of transplant itself, and so went over some of these things, and I think we'll touch upon some of these again today in his talk. I think adherence to medication is a huge issue that I think we're beginning to really focus on, not for the first time, but I think at a level that it needs to be focused on, because adherence is a problem, particularly in the pediatric population, as they grow up from kids to adolescents and young adults, that really deserves a lot of attention. So this is just a paper looking at adherence to medical regimen after pediatric liver transplantation. This was kind of a systemic review, so a broad look at the literature. Non-adherent rates for immunosuppression is high, right? Not really a surprise to any of us, but upwards of a third of our patients are not adherent to their medications. Risk factors for non-adherence, I don't think surprising to anybody, would be things like older age of the patient. There again is the adolescent, low family cohesion, poor social functioning, mental health, and single-parent families. Again, I don't think any of these are surprising, but they are important to note so that we can address them in our patient population when we know that they exist. Again, this was a meta-analysis, so it used different definitions of non-adherence, and it only looked at kind of single time points based on the literature. This was a paper done by Eyal Shemesh in New York and John Bukavalis, who was in Cincinnati but is now in New York. This was an NIH-funded study called the Medical Adherence in Liver Transplant, or the MALT study. And this really was important because it looked at trajectories over time and looked at patterns and changes as it relates to non-adherence. So almost 60% of patients who were non-adherent in year 1 post-transplant remained non-adherent in year 2, so not surprising. Almost 20% of patients who were adherent in year 1 became non-adherent. So just because you were adherent, kind of in that immediate perioperative period didn't mean that adherence stuck. Only 4% of patients who were adherent in both years had a rejection, compared to 23% who were not adherent during one of those years, right? So again, not surprising, but important, in that if you can keep it, adherence is one of those key things that relates to outcomes. And so I think, measuring and looking for adherence in our population is critically important. And then again, one of the risk factors that kind of came out was the single parent household. So, the results from their study suggest that, good baseline adherence does not guarantee continued adherence, that non-adherence is likely to persist in the absence of intervention. And I think that was key in this study. They didn't intervene when they saw non-adherence. They were just kind of recording. And that monitoring of adherence and interventions to improve it should be expected to last for years. This is something we'll have to go back to again and again and again. You can't just address adherence, once at a clinic visit post-operatively and expect that to be the only time we discuss it. Risk of rejection and infection. Again, I think Dr. Schultz touched on a little of this yesterday, as you think about heading into transplant for PFIC. But immunosuppression is always this balance between too much or too little. Too little risking things like clinical and subclinical rejection, too much leading to things like infection, PTLD, and chronic kidney disease. I showed this slide just to show, some of the immunosuppressions that we use to prevent rejection, which is generally a T-cell mediated process. And so there are various drugs, whether it's thymoglobulin, various antibodies, basiliximab, cyclosporin here, tacrolimus here. If there are any post-transplant patients or families on the call, you will recognize some of these medications. And we use these medications to combat the immune system in order to prevent rejection. Right? T-cell normally functions to kind of recognize foreign things in our body, including viruses and transplanted organs. And so we look to suppress that. But when we do that, if we lower that T-cell function, you do risk infection. And I think the big infections that we look for are cytomegalovirus, adenovirus, Epstein-Barr virus, and others. I'll focus just briefly on Epstein-Barr virus. And again, I know Dr. Schultz, for those of you who listened yesterday, discussed this as well. Because EBV is really the virus that leads to one of the complications that we worry most about, which is PTLD. PTLD stands for post-transplant lymphoproliferative disease. It's a disorder of lymphoid proliferation in the post-transplant setting. It is typically due to immunosuppression and EBV reactivation. Right? So what is EBV? Well, it's this ubiquitous HHV or herpes virus. It enters the human via mucosal route. It's incredibly common. Almost everybody has it or has been exposed to it. It replicates in the oropharyngeal epithelial cells in our mouth, and then it infects B cells. QBBV, I think most of us know, is mono or mononucleosis. These are symptoms that generally last 2 to 6 weeks. They often occur with primary infection in older children and adults. And notably, even just a primary EBV infection in an competent person can be severe. But most of the time they're self-limiting. These infected B cells, once the virus is in the body, don't really produce virus, but instead they make what we call latency-associated proteins. So this allows the virus just to kind of hide in our bodies. Again, most of us who have had EBV, it remains in our B cells, but just kind of sleeping, but our immune system generally keeps it at bay. But now that these infected B cells are indistinguishable from normal memory B cells, again, it is kind of invisible. I won't go too in depth of this slide, but again, this just kind of shows the life cycle of EBV entering via the mouth, getting in the epithelial cells, infecting B cells, and then hiding out inside the B cells. You can see here that, again, depending on which stage the proliferation takes place, you may get different types of cancers. And again, PTLD is a lymphoproliferative disorder, so it is a cancer that we worry about. Again, typically though, if we notice PTLD or if you have EBV and it's trying to reactivate, your T cell is there to kind of knock it down. And so many of us don't get cancers when we get EBV. None of us do if we have a healthy immune system. But again, if we're knocking out that T cell, as we need to do with our immunosuppression, we risk the development of these cancers. PTLD typically occurs in younger versus older patients. There is a difference in the type of organ that you got transplanted. You see there that the incidence is most high in the lungs, but there's liver right at second, and then heart, kidney below that. Donor recipient status is a risk factor. So if the donor organ is coming from someone who's EBV positive to a patient who's EBV negative, which is not uncommon in pediatrics in those smaller kids who haven't been exposed yet, that's a risk factor for PTLD. And then there's likely some unknown specific immunosuppressive effects that increase risk as well. Late allograft complications, and I'll just show this one slide. We did kind of look at our larger experience within the split of the Society of Pediatric Liver Transplant. And so you can see there at the bottom, the colors indicate reasons that a graft was lost within 1 to 5, 5 to 10, 11 to 15, 16 to 20, and greater than 20 years. And I think the big ones, as you kind of get further and further out, are things like again, chronic rejection is a very common one. I think you see that more and more and more. Thrombosis typically occurs early, but then falls away later. Infection is always a risk throughout the entire time point. And so, I think there are various reasons why. I think this noncompliance, as we talked about earlier, is probably underrepresented. There's probably a fair number where, even if we can't label it noncompliance, probably that noncompliance led to chronic rejection. And so some of these are kind of, it's important. You can't really tease them out per se. But there are causes of late graft loss, and we do worry about kind of the patient who's 15, 20, 25, 30 years out, particularly in the pediatric population. But oftentimes, I can't tell a patient, my 6-year-old patient who's getting the transplant, what life's going to be like at 50 years old. Because we don't have that type of outcome, right? I mean, Starzl did the first transplants in the 60s, but in reality, I think any real numbers we don't really have until the 90s and really early aughts. And so 20, 25 years is kind of, pushing the limit as to kind of meaningful data that we can describe. So, we don't really know what a liver transplant patient will look like who gets transplanted at age 5, what they're going to look like at age 75, although we expect them to get there. And then quality of life. Again, Kyle talked about this yesterday, right? But it's not just, we think about outcomes, we think about is the patient alive, is the liver alive? And those are kind of the two main outcomes that we typically will look at. But in children in particular, it's much more than that, right? And so, this group, the split group, again, looks to define what we call the ideal post-transplant patient, right? So what is the ideal patient that we're looking to get at 10 years? And so we wanted a stable allograft, so no retransplant, no chronic rejection, normal liver numbers. We wanted to avoid all immunosuppression complications, so no PTLD, normal renal function, which can oftentimes go in the face of some of these immunosuppression medicines, and normal growth, right? I think that's something that's also critically important, is that we want our children to grow and develop. And then avoid additional treatments, right? No prednisone or other steroids, no antihypertensive agents, no seizure meds. And at the end of the day, we have a lot of work to do in this area, right? Kyle presented the more granular data yesterday, but only about 1/3 of our patients reach this ideal outcome. And so there's a lot of work trying to figure out how we can improve that number over time in order to really not just look at graft and patient survival, but look at the whole patient. So what about, specifically for PFIC, right? We talked about how there are transplant experiences in all the PFICs. But what about some of the unique considerations? And I think these are most prominent in the PFIC 1 and 2. And I don't think that that's news to the folks on this webinar, but I think we'll touch upon it here towards the end. So PFIC 2, again, I think the biggest concern about PFIC 2 is the risk of recurrence. And so, this is one of the first papers to describe these relapsing features of BSEP deficiency after transplantation in 2 patients. And so, again, this described liver transplant in 2 patients with ABCB11 deficiency at age 9 and 2.8. They developed cholesterol with low GGT, cholestasis with low GGT developed at 17 and 2.8 years after liver transplant. And again, I won't get into the weeds on this picture, but what they showed was in these patients, when they went looking for that BSEP protein, it was no longer there. And I think that's most represented in this top G box, right? So there is a stain when you do a liver biopsy that you can look for the BSEP protein. And I think, again, it's in this picture here. Normally you have this kind of linear pattern of the BSEP where it lines the kind of canalicular space. And again, you see these kind of feathered appearances. But in some of these patients, when they went looking for it, they saw no evidence of any BSEP there. And so what they surmised, or what has been kind of shown, is that in patients who get transplanted for BSEP, they oftentimes have no BSEP protein, right? They have a mutation that causes them not to make any. And so the body's never seen a BSEP protein. So as you put a new liver in with that new protein there, the body will actually develop antibodies specific to that BSEP protein. And so we'll kind of destroy it over time. And so, how do you treat that? Well, the treatment that has emerged is this medicine called rituximab. And rituximab is essentially a medicine that knocks out B cells, which makes antibodies. And so if we think that this is an antibody-mediated process, we will treat it with a medicine that suppresses antibody production. Not every patient transplanted for BSEP develops recurrence, but it is something that we now watch for. And if there's any suggestion of its development, we will try rituximab in order to kind of knock it down when it's rearing its head. What about PFIC 1? Again, this is kind of just a table showing kind of a case series of patients transplanted for PFIC 1 or FIC1 deficiency. And I think some of the biggest complications that we worry about in FIC1 are the extrahepatic complications. So FIC1 is the only PFIC that actually has extrahepatic manifestations, the big one being diarrhea, but also pancreatitis, hearing disorders, and other things. And what you see is that almost every patient after transplant developed worsening diarrhea, even if they went into it with diarrhea, it worsened. And some of the other extrahepatic complications, such as pancreatitis, they recurred after transplant as well. I think one of the other big complications that we've seen in the PFIC1 population after transplant is the development of intrahepatic steatosis. And this steatosis, which means fat in the liver, and that's these white globules that you see here. That's all fat that's in the liver that shouldn't be there. Fat in the liver is not good. It can lead to inflammation, and inflammation generally ends in scar. And so there has been reports of patients who develop steatosis after transplant that end up developing scar tissue and ultimately needing a retransplant. And so this is another kind of devastating complication where you've already gone through one transplant and now your new liver is needing to be replaced because of progressive steatosis. In order to combat that, some patients have looked to kind of, re-implement biliary drainage via either internal or external diversion in order to prevent the steatosis. And here was one group when they looked at their post-transplant liver. Again, you see all that white spot. That's all fat that's in the liver. It's developing this kind of scar tissue, which is the blue kind of line that's connecting those two areas. But when they kind of re-diverted or re-drained the patient via this way, right? They took a loop of bile, tacked it up to the bile duct that's supposed to drain into the intestine, but bypassed kind of the way that the bile acids get reabsorbed in the terminal ileum. What they showed is that steatosis went away. Here's another group that decided in order to kind of preempt this, and instead of saying let's do a transplant, wait for the steatosis, and then divert, let's just do a total internal diversion at the time of transplant in order to kind of prevent its occurrence. And so again, just a picture showing how they hooked up the drainage of the liver into the large intestine, thereby bypassing the way that bile salts normally get reabsorbed in the terminal ileum. And they saw there was really kind of very minimal evidence of steatosis after that transplant, right? As compared to those other pictures we saw, those big globules here. There's some, it's not perfect, but it's minimal. And so they suggest that this is a strategy for patients getting transplanted for PFIC1 to prevent this complication. So, conclusions here, and again, I know I went quickly, but I want to make sure that we have plenty of time to kind of talk about any particular issues that arise. But, life after liver transplant for PFIC is in many ways similar to those transplanted for other indications. We worry about all of those same complications, particularly in children, that we worry about that we have transplanted for any other indication. There are PFIC-specific complications that we know about, that we monitor for, that we're gaining knowledge on. There are some emerging mitigation and treatment options available to try to prevent their development or treat them when they come. But as was kind of discussed yesterday, we need to study more. We still don't know so much about these conditions and why necessarily they develop some of these complications. And so, I thank you for your time. Again, I know I went quickly, so hopefully it was helpful. But I think if there's any questions or open discussion that we want to have, I'm happy to kind of have that now.
Awesome. Thanks for that. And I know, so when Dr. Soltis, if he does emerge from the OR, I know that he's going to go further into some of those complications that you mentioned. But we can start some Q&A around those if that arises, because I know that there's some interest on the call. I wanted, before we get into some of the live questions, you spoke quite a bit about medication adherence and how important it is. And we actually talked about that a little bit yesterday related to PFIC specifically. And it was, I struggle to say less important because it's not less important, but here it's vital. Can you kind of just like break down adherence, honestly in layman's terms, and then what that kind of entails and why it's so important in transplant?
Yeah, sure. So, and it's important here because people will use terms interchangeably, like adherence and compliance, right? But oftentimes, adherence is looking for barriers to taking your medications regularly, versus compliance is that patient who says, yeah, I know I'm supposed to do it, but I'm just not going to. And so I think, there's some definitions to make sure that we understand the differences between them. But when we talk about adherence, really what we're getting at is trying to make sure that patients understand the medications they're supposed to take, why they're taking them, what they mean, and how we can ensure that they take them every day. And part of the responsibility is on us to, again, educate and make sure that we're not overburdening our patients, right? It's easy to sit in the office, write off a script, and send the patient home, right? But if that's the 20th med the patient is taking, right? We know that there's good data that for every additional medicine that's prescribed, you are risking, the development of non-adherence. because we are complicating their lives. The discussion yesterday about adherence is recognizing that for, particularly for, kind of the PFIC disorders and the supportive care that we often get before transplant as it relates to pruritus and some of those other things, those are really strategies to make the patient's quality of life better. What there isn't, and again, I need to be careful because I don't think we know this for sure, but there isn't evidence that if I give you a medicine and I lower your itch, that the act of lowering that itch also, because of the way it's acting, prolongs or interrupts the natural history of your disease, right? And so for a patient who maybe isn't itching that much, and a kid saying, I don't want to take my medication or I forget all this time because I don't itch that much, there's no data that says, well, you should be taking it anyway because it's good for your liver and it's going to prolong your native survival with that liver because you're taking this medication. Post-transplant, all that's out the window. We know post-transplant, the biggest risk of losing an allograft or a transplanted liver is medication non-adherence and non-compliance. Because we take these medications because we need our immune system to be set at bay a little bit so that it accepts this organ. Now, I think the pushback on that, and where there is still, again, a lot of study, and this isn't unique to PFIC, is that the right amount of immunosuppression for any individual patient who's been transplanted is as little as possible, right? For those reasons that we just talked about. There are complications that immunosuppressive medications induce in a patient. And so we want to make sure that we can give as little as possible to allow your body to accept that organ without developing complications of rejection and the like. But that's different for every patient, and that's different for different organs. There are patients out in the community who are able to withdraw medications entirely. Again, sometimes we have to do that because of medical complications like PTLD, where one of the first treatments is to withdraw immunosuppression, let the immune system wake up and try to fight off what we think is a viral-driven process. There's some patients who, you kind of lose them in follow-up. They're 5-10 years out. They haven't come for their annual visits. And by the time you see them back, they kind of have stopped taking medicines for 3 years. And when you look, the liver seems to be happy. We never recommend that. But, that's something that has happened. There is a study called the IWITH study, the immunosuppression withdrawal study, that's actively looking to understand who are those patients that can come off immunosuppression and why is it that some can come off and some can't. We don't know those answers yet. Again, we have the advantage in the liver world that the liver is a rather immune tolerant organ, as opposed to kidney, heart, lung. You'll never be able to come off immunosuppression if you have a transplant for those organs. But the liver seems to be able to tolerate some degree of immune reactivation without having too much trouble. Again, I think the answer to your question is, the adherence issue pre and post transplant is talking about what you're adhering to. And adherence to medications that are going to enable your transplanted liver to stay in your body and not get rejected is critically important. And we know what happens if you stop taking your immunosuppression medication, particularly early on. In the pre-transplant setting, it's a little bit more difficult because it's not entirely clear that the medicines that we're giving to treat symptoms are necessarily changing the natural history, although they may. And I think that's an area that, again, people are looking at and we still need to try to better understand.
Okay, great. So before I get to some of these more specific questions, there's one more thing I kind of want you to explain in general. So especially during COVID times, there's a lot of attention on immune suppressed patients. And I get all the time, what does that mean? So my daughter's been transplanted. How is that, what does that mean for my daughter? Like, does she have any immunity? If I beefed her up on vitamin C and bone broth and did all the natural things, is that something that kind of helps beef up her immune system? Or are we just simply not able to, we're not giving her immune system at all, so she's not able to fight infections like that? I think there's a lot of attention on that. And sometimes I struggle to answer those questions even as a nurse. I mean, I understand scientifically, but it's kind of difficult to explain these things to the public, let alone understand myself where she's at with her ability to fight infection.
Yeah, sure thing. So, I mean, I think we have to be very careful here in that, in the era of COVID, we have very little data to drive definitive answers, right? I mean, this virus has been with us for 10 months, and so I think that, it's very, very difficult to be able to say a whole lot, clear cut. I think B, it's important to recognize that when we talk about immunosuppression, there are various degrees of immunosuppression, right? There are patients who have many different diseases that takes medicines that suppress different parts of the immune system. And so not every part of the immune system is the same. And not every patient that's taking an immunosuppression medication is the same, nor are they equally immunosuppressed. I think that there is a guidance document, and this mostly deals with kind of going back to school for kids that was put out by the Infectious Disease Society, and that I'm happy to kind of forward to you, Emily, that I think is a great resource, kind of just talking. Now it is kind of specific to solid organ transplant, but I think it talks about degrees of immunosuppression. What are some of the risks as we think about who should be put under certain restrictions. And so I think that. But at the end of the day, these are just expert opinions. These are just getting, a few smart people in the room and saying, what can we kind of agree on to get out there and push out there to the public, because there isn't, any sort of real longitudinal data or study. Now, the post-transplant setting, right? One of the things that we have not seen is this large, rush of patients in the post-transplant setting that have come in with COVID infection. That hasn't happened on the adult side. That hasn't happened on the pediatric side. That really hasn't happened in any immunosuppressed population. Now, yes, there are cases. Yes, you will come across experiences, but it is not something like, for example, HIV/AIDS, where you saw certain infections really kind of overwhelm this population because of their immune system. We have not seen this infection overwhelm populations of immunosuppressed patients. Who it seems to overwhelm is older patients with other comorbidities, mainly obesity and diabetes. Now, again, we don't know why that is, but I think when you look at the data that's at hand, that's what we are seeing. And if anything, we are seeing that there are some patients, or there's some evidence that immunosuppression may have some protective effect. Now, again, we wouldn't suggest that everybody then start immunosuppressing themselves. But I think that there's evidence to suggest that those who get sickest with COVID may do so not necessarily because of the initial infection of the virus itself, but actually the immune system's kind of reaction to the viral infection. So you get the virus, the immune system kind of goes haywire, and it's kind of that cascade of immune inflammation reaction to the virus that causes a lot of the really bad sickness, more so than the virus itself. This is why I think when you read in the papers, the headline will be, simple, medicine that's been around forever seems to help COVID patients, and that simple is steroids, right? There's the clinical trial that shows if you give steroids to patients with COVID infections, you prevent some of the rapid deterioration. All that is to say is that I think that there are degrees of immunosuppression that I think people need to think about with their individual patients. And I think obviously, in a post-transplant setting, a patient that is, within the first 6 months of transplant, where the immunosuppression medications are very high, where they're being adjusted. If there's a patient that's further out that has a rejection episode where the immunosuppression medications are needed to be increased acutely, these are settings that we will worry a little bit more about, but only because we worry, right? There's no data that these kids are necessarily getting infected at a higher rate or having more complex infections when they do get infected. But that would be a situation where we would maybe worry a little bit more about, for the most part, we think that patients who are, a year, 2, 3 years out from transplant, who have no, recent changes in their immune suppression, who are on kind of minimal tacrolimus dosing in the kind of, 2, 3, 4, 5 range, that those patients, it doesn't appear at any increased risk of getting the infection or having a severe complication than the general population.
Okay, and just because it kind of naturally came up, and then I want to circle back to transplant, what about the pre-transplant, just patients who are diagnosed with PFIC? Are they at any higher risk for developing COVID?
I mean, obviously, right, now you're talking about a rare disease with a brand new virus, right? So there's absolutely no data, as far as I'm aware, of patients with PFIC who have had COVID and what it means for them. But if I think about it mechanistically, I wouldn't be able to link, there is just kind of a registry looking at just kind of chronic liver diseases. And just, again, liver diseases in general don't seem to put patients at any increased risk for COVID complications. Does that mean that you can't get COVID and that you can't have a severe complication? Absolutely not. But it doesn't appear that there's an increased risk as compared to anybody else in general population.
Okay, thank you. I appreciate that. I kind of put you on the spot with that one, but I know that it's kind of a lingering question with any, chronic disease population, so it's helpful.
You can put me on the spot, Emily. I may or may not give a good answer, but I don't mind being put on the spot.
Okay, well, I'm going to hold you to that. Okay, so back to some of these transplant questions. Are there, documented complications after liver transplant for PFIC-3 patients? Let's see. So for PFIC-3 patients specifically, and then there's kind of a follow-up in there, there's already been patients shortly post-transplant and they've had a liver biopsy that doesn't show any rejection, but does that mean that they won't show rejection? So that's kind of two questions there.
So specifically to the PFIC-3, as far as I'm aware, there isn't any good data that PFIC-3 carries a specific risk for post-transplant complications. BSEP is the big one because, again, it seems to be the protein itself the body can develop an antibody to. For FIC1, it's not necessarily, it's not a liver complication, right? So the complications that develop aren't related to the body's recognition of the FIC1 protein, but it's the fact that that FIC1 protein is not just in the liver alone. And so when you do a liver transplant, you don't fix the FIC1 deficiency that's in the gut or the FIC1 deficiency that's in the pancreas. And so they can still get the diarrhea and still get the pancreatitis. For MDR3 deficiency or for PFIC3, it appears as if you replace the liver and the MDR3 protein is mostly entirely in the liver, that you then fix that problem and that there isn't any specific complications that you need to worry about outside of those traditional transplant-related complications. I'm sorry, the second question was?
This patient is shortly post-op after a transplant. Yeah, just wondering about if there's no rejection in the first biopsy, but does that mean that there won't be any rejection from now going forward?
No, absolutely not. Right, and this is why it's critically important in the post-transplant setting to listen to your care team. They will often have some sort of protocol to monitor your labs regularly, whether that's every month or every 2 months or every 3 months. And I think following those liver numbers, I think most people have also moved to doing what we call protocol liver biopsies. So generally a biopsy at year 1, year 5, year 10, or at some regular interval, even in a setting of normal liver numbers to look for kind of chronic changes that can occur even with normal liver enzymes. And so I think that rejection can occur at any time. Even far out, it can be an acute rejection, right? So we typically think of acute rejection as something that occurs in the early post-transplant setting, but acute rejection can occur at any point. And so I think, but what's going to key someone into a rejection event is generally going to be liver enzymes, and I think so that's why getting regular lab monitoring and discussions with your team are going to be critically important.
Great, thank you. So I have a question specifically related to PTLD. So there's a few questions in here, so I'll ask all together and then I can break it down. So other than the blood, EBV, and PCR test, what is done to monitor and treat for PTLD before it progresses? Is there a certain viral load number where you would look to where treatment would start? And then what does treatment look like for PTLD at that point?
That's a fascinating question, right? So we actually just had a big group convene. Well, now it was kind of the pre-COVID era, where they had some, infectious disease specialists, transplant hepatologists, transplant surgeons, from every organ system meet in Nashville for kind of this big meeting on PTLD to try to come up with some, working guidelines, definitions, things to move forward with. Because at the end of the day, I think obviously this question is rooted in, maybe some personal experiences. There is variability in practice and there's variability in definition. And what I mean by that is, for example, after transplant, transplant teams will also often follow what we call the viral load, right? So at least every year or sometimes more frequently, patients will have their EBV virus measured in their blood. Obviously, normally you'd like to see that be 0, but sometimes you get a measurable load and then they follow that. And if it goes up and up and up, sometimes you will think about lowering immunosuppression in order to, again, allow the body to wake up a little bit and fight off that EBV virus. But there are some patients out there who actually have what we call high viral load status or high viral load carriers. Well, they will have tens of thousands of virus in their blood, but it doesn't seem to be doing any damage or causing any problems. Oftentimes we will think about doing CT scans or imaging on these patients to look and make sure that there isn't an area that looks concerning, because most of the time PTLD shows up in a lymph node or something. But in the absence of radiographic evidence of disease or other symptoms to suggest, these are very difficult decisions to make, right? Because you don't want to necessarily withdraw immunosuppression entirely and risk rejection in someone who just has a high viral load that's not causing any damage. But who that patient is it's a nuance to really get at, how you're going to manage that in that kind of singular patient. But clearly, the patient who has the high viral EVV load, we're going to be thinking about, monitoring for suggestion of PTLD much more frequently, or have a lower threshold for kind of getting things like CT scans and endoscopies and things of the like, in that patient than maybe another individual patient. There are, maybe physicians who would think about giving a patient like that something like rituximab, again, that medicine that we talked about that treats PTLD, but also kind of kills off the B cells. Because even if you think the virus is just within the B cells, because that's where it lives, if you can get rid of the B cells, maybe you can get rid of the virus in its high viral load status. But, again, there's risks to kind of killing off all your B cells. And so I think you have to balance all of these pros and cons and kind of look at the individual patient, have a discussion with your care team, and figure out how collectively you guys are going to monitor that and move forward. But it's not always easy.
Okay. Follow up to that, how does the endoscopy look for PTLD?
Yeah, so I mean, again, the gut is a very lymphoid heavy tissue. So there's a lot of lymph tissue in your gut. And so that's where a lot of it just kind of exists. And so, you can get PTLD anywhere. But one of the common places that it will show up is in the intestine. And so for a patient who may have, you'll get a CT scan and you'll see some lymph nodes around the intestine. If they're having some, any sort of evidence of kind of GI blood loss, they're anemic, you test the stool and it's positive. Sometimes you'll do an endoscopy and you actually will see a lesion within the intestine. And so that's why you would do endoscopy if you felt like that was going to be a place that you were going to be able to see a PTLD lesion.
Okay, thanks. Okay, I have kind of a general PFIC question, but I'm going to tie it into this transplant conversation in a different way as well. So there's a few new patients, newly diagnosed patients or parents on this call. And so specifically in PFIC-1, the question is what is the chance that you could cure a patient with medication only and not lead to liver transplant? And I'm going to spin this in one way. So I want you to answer that, but then also, so our patients are all over, of course I am, I'm sorry, I have to. Our patients are all over the world. And in some areas of the world, transplant isn't an option or it's not accessible for various reasons. So, this might be something that might be important to discuss in patients that might not have that option as readily available is a poor way to say it, but you know what I mean, that isn't involved in a healthcare system that, does as many liver transplants.
So I think the answer to the first question is, so not all PFIC is the same, right? We talked a little bit about this yesterday. And so just because you've been given a diagnosis of PFIC-1 doesn't necessarily mean that you're going to fit the most dramatic phenotype or physical manifestations of that, which is that very, semi-rapidly progressive disease that generally within the first 10 years of life needs a liver transplant. The spectrum of all the PFICs is variable, right? And this is why, when you look at BRIC, right, which BRIC stands for benign recurrent intrahepatic cholestasis, through PFIC, there are patients that will kind of fill out that entire spectrum. And so I think that not everyone who, has a diagnosis of PFIC necessarily is going to progress quicker than, or, as quickly as another patient. And so, I'm hedging here, right? But I think it's important to recognize that, you will read about PFIC and it says, oh my gosh, every patient's going to progress and need a liver transplant. That's not entirely true. And you could have more of a, phenotype that lends itself more to kind of less progressive disease, or even disease that doesn't look like it's progressing much, but just kind of will intermittently get cholestatic. And these are the same proteins. It depends on how dysfunctional that protein is, right? And so what we're learning more about is how like specific genetic defects lead to phenotypic or physical manifestations in an individual patient. So that's important to recognize. These proteins, these are the same proteins that are defective in drug-induced liver injury in some patients. These are the same proteins that are defective in intrahepatic cholestasis of pregnancy in some women. And so I think that, if a child presents that as jaundiced, and then we do genetic studies and it says, yes, they have defects in FIC1, in the ATP, gene, then yes, technically they will fall somewhere along the spectrum. But where they fall along that spectrum is variable. And so there may be a patient who, has a more favorable genetic defect where medicines do seem to really help. The patient may not progress to need a liver transplant as a child or even as adult, and may just have, kind of recurrent episodes of cholestasis. And so would be more of the brick phenotype. There's another patient who, no matter what medicines we use, no matter if we divert them or not, I think, Kyle showed the NAPIT trial yesterday, right? Or the NAPIT study, looking at mostly BSEP, although they have some data on the FIC1 patients too, showing that, depending on which defect you had, it didn't matter what you did, you were going to be headed to transplant. And so I think that, we just have to be a little bit careful when we say this patient has PFIC, that doesn't necessarily mean that they're going to have one outcome or another. We have to start digging a little bit deeper as, what's the manifestations, what's the specific genetic defect, and is there any data to suggest that the outcomes in that kind of subpopulation is going to be any better or worse? Now, your second question was about not readily available transplant. So again, I think it just depends. If you have a more severe defect where there's progressive disease that occurs rapidly, I think there's oftentimes not a whole lot we can do medically to prevent that patient from progressing. Now, again, some of those new therapies that we talked about yesterday, I think the IBAT inhibitors, there's a lot of hope for those, right? And as they're currently being studied, they're really looking to kind of study their effect on itch more so than their long-term effect on outcomes. Part of that's just because of trial design and what you're using as study endpoints, right? If we talk about this as a progressive disease, but it takes years to progress to liver transplant, it's hard to run a clinical trial in a drug where the outcome is, what do they look like 5 years from now? That's a very expensive study to do in a very rare population. And so, the thing about itch and bile salts is that, those are endpoints that we can get within a few months or, a year or so. So that's why they've chosen to look at those specifically as the endpoint. But I think there's still hope that if we know, for example, more so in the FIC1 deficiency than BSEP deficiency, that diversion does seem to really interrupt the natural history of that disease course, right? And so if you can divert medically or chemically with the IBAT inhibitors, can you get that same effect? We don't know. There's hope, and we would like to think that that's possible. And so for a patient that may be outside of surgical expertise, whether it's transplant or diversion, would an IBAT in the future be a medicine that really interrupts their natural history and prevents them from needing transplant? Is that possible? Sure. And I think we all hope for that. And maybe there's other medicines that are in the pipeline, but those aren't readily available just yet. And so for a patient who has a severe phenotype, all we could say is, to do what we can to try to get that patient to a transplant center, because there's probably very little in the way of pharmacotherapy that's going to prevent that liver disease from progressing if it's a more severe, progressive type.
Okay. Again, I feel like that's a topic we could have an entire discussion about, but
Sure.
We're going to be inviting you back for follow-up at some point. I'm going to get to this question here. And I'm going to read it mostly word for word. In the case, there's two children with PFIC4 or TJP2. One was transplanted already after nodules were seen on the liver, and then the other is pre-transplant with PEBD, with diversion, external diversion, no significant issues. For the pre-transplant kiddo, would it be worth pursuing transplant before turning 18 to take advantage of the pediatric transplant priority?
Talk to your team about that. I mean, this is where I'll get all riled up, and I got to stay focused, right, on just how organs are allocated to kids or not, and
I kind of want your riled up answer, to be honest.
No, you don't. You really don't. So, I mean, I think at the end of the day, sure, there are advantages to being listed for transplant before the age of 18. But I think that there are still, transplant is not risk-free. And so if there's no real indication for transplant, even though you have a disorder that can lend itself to transplant, I wouldn't necessarily push to be listed for transplant. You don't want to be listed for transplant unless you're ready when the team gets that call for you to say, okay, I'm going to get transplant, right? And I think that's something that I talk with my families about, right? Is if I list you for transplant and I call you tomorrow because there's a liver, you better be ready to come in. It doesn't work that you can be listed and then kind of get the call and be like, well, no, I'm not ready, not yet. That's not how, it's not going to be that interrupts the process. That's not a good plan to have. And so I think that, but there are still instances where we will take advantage of, someone who we think may need a transplant in the next couple of years. And PFIC's tough because, again, you don't know exactly, particularly TJP2, because there's so few of them. But I think that, there are definitely instances where here at our program, we will think about getting the kid on the list early because they've got a disease that we definitely think, although they may not need a transplant right now, they're going to need one, sooner than later. And we do take advantage of that pediatric transplant listing. But I think that's a discussion to have with your team, kind of with them recognizing what do we think is going to be your 3 to 5 year outcome? Because I think if it's beyond that, that the transplant's not needed, then I wouldn't think being listed is going to be that beneficial.
Okay, and I actually had kind of a general question about something similar. So can you explain the PELD and the MELD scores? Because I think that kind of hits, we're talking about system now. And so, not everybody might understand, advantages of a pediatric system or an adult system, and just kind of generically what goes into both systems.
Yes, part of it is that this is changing, right? The way that, kind of organs are allocated, and this is always a kind of a bit of a moving target. So PELD stands for the Pediatric End-Stage Liver Disease Score, and MELD stands for the Modified End-Stage Liver Disease Score. There's a history about the PELD and MELD. I could kind of pull up slides and give a whole other talk on this, right? But it used to be, prior to the year 2000, there was something called the Child-Turcotte-Pugh score, which is a different kind of score that, when we talk about these scores, we're essentially trying to take data from the patient and their blood work and then figure out, who's going to need an organ first based on that data. And so it used to be that there's something called the Child-Turcotte-Pugh score, and it had some variables that were somewhat objective, like encephalopathy, right? Encephalopathy is what we talked about a little bit yesterday, where you can have high ammonias and it can cause you to kind of be a little like, foggy. And actually, it can, it causes brain swelling, so it's a terrible thing. But the initial kind of symptoms of encephalopathy are like, slowness or kind of confusion or kind of stupor, things of that matter. And you try to gauge encephalopathy in a 2-year-old in the hospital, that's impossible, right? If they're cranky and fussy and tired, that's just their 2, right? Are they stage 4 encephalopathic or are they 2? I don't know. So I think that, because of that, and then along with the Child-Turcotte-Pugh, it was time on the wait list, right? So when they were divvying out organs, it was who had the worst Child-Turcotte-Pugh score and who's been on the wait list the longest. And so because of that, if anybody ever thought you needed a liver at any point in your life, the doctor would list you right then and there. Because when and if you did need that organ, if you'd been on the list for 17 years, you had an advantage over someone who'd been on the list just a year, even if, their disease was maybe subjectively worse than yours. And so the Department of Health and Human Services, at least here in the United States, decided we're going to take away some of these objective measures, right? So we're going to try to take away anybody's objective feelings about this patient, and we're going to take away, how long you've been on the transplant list as factors that go into this. And they challenged the transplant community to say, come up with something better. And so what they came up with is what was initially the MELD score, or the Modified End-Stage Liver Disease Score. The MELD scores was typically given for adults, and it includes things like INR, albumin, and creatinine. creatinine being more of a reflection of one of the complications of hepatorenal syndrome that we briefly talked about yesterday. That's common in adults. Hepatorenal syndrome is very rare in kids, and when they actually looked at the MELD score applied to children, it didn't do very well. So again, the reason that creatinine was in there meant that most of the adults had much higher score than kids. And so the pediatricians were like, no, that's not cool. We're not going to use this score on our kids because our kids are never going to get organs. And they recognized that. And we said, okay, yeah, you're right. So come up with a pediatric score. And so that's where the PELD score came out of. The PELD score is a pediatric specific score that removes creatinine and puts in a few additional things, and also takes into account growth, right? Adults, you're not worried about their growth and development, but in a child who's not growing because of their liver disease, that's a substantial problem. And so I think that, and age, because we know that kids less than 1 are particularly at risk for poor outcomes. And so kids less than 1 and kids that aren't growing get even higher scores because of those unique considerations in pediatrics. And so, the PELD score and the MELD score, and so again, you use the PELD score up to 12 and then the MELD score above that. So now these scores are used to kind of dole out organs, but there were problems with that system as well, right? And so one of the problems is, I can have a child with a PELD of 27, but I still think this kid is way sicker than that, right? And so the community said, well, fine, if you don't like these scores, you think these scores aren't perfect, we'll allow what's called exception points. And exception points are essentially, if there's anything that I feel like causes my patient to be sicker than the score reflects, I can ask for additional points. And so although that was initially built in to kind of recognize that these scores aren't perfect and that there are, again, exceptions that should be considered in individual cases, at the end of the day, that has caused everybody to ask for exceptions for all kinds of things, most of which gets approved. And so you had actual calculated scores, but almost nobody got transplanted with their calculated score. They were all getting transplanted with these exception scores. And so I think that, they are constantly working to try to improve how these things are allocated. It's still not a perfect system. We've now moved away from what used to be kind of 11 UNOS regions in the country to now just acuity circles where they look at distance of organ and patient to try to dole out things. But this is a moving target. There is still, and I think the new system, the more we've chipped away at it, is improving transplant for children. In the fact that if there's a pediatric organ available, it's going to go to a pediatric recipient. If there's a sick pediatric kid, they're competing with the sick adults, but I think that, the pediatricians are still trying to advocate for kids more and more, right? I mean, if you think of quality of life years gained from a liver transplant in a 6-year-old versus a 67-year-old, I'm totally biased and I know that, but I would think that any liver should go to that 6-year-old first, particularly because of many of the diseases that adults are getting transplanted for, like alcoholic hepatitis, fatty liver disease, and the like, are kind of preventable. This kid here with B-cep deficiency was no fault of their own, that they got this sick. But again, I'll get off my soapbox and I don't know if I answered the question correctly. It's not a perfect system. It's constantly being rearranged. Pediatrics, there is some advantage of being a child, but there's still way more adults than kids. And so we have a lot of work to do. And there are still kids that die waiting for a liver, and that's unacceptable.
I agree. Thank you. I like your soapbox. I'm glad that you got on your soapbox there for a minute. I realized that was a weighted question. I'm going to step back a minute. We have a question. We kind of discussed it yesterday. I can't remember if it was when you were off the call or not, but it's more medical treatment related. 2 questions. Can URSO stop the progression of liver disease? And do you have any experience with hyperbaric treatment for patients in our population?
I have no experience with hyperbaric treatment, so I don't feel like it would be fair to me to comment on that. I know there's some reports out there, and hyperbaric therapy is not just for progressive liver disease. There's all kind of, I would kind of put hyperbaric a little bit in the kind of alternative complementary, arm of medicine. I think all of these things need to be studied. Recognizing that it's almost impossible to study them meaningfully in rare disease, and so that's kind of a catch-22. But I think I'd probably hold my comments on that because I really just have no experience. Ursodiol, I think, is as we talked about a little bit yesterday, a medicine that we often use because of its safety profile and because it definitely makes numbers appear to get better. It's not entirely clear that it changes clinical endpoints or prevents progression of liver disease. That doesn't mean that I don't use it on every patient that I take care of with PFIC. I definitely do. But I also don't sell it as, this is going to cure your disease and should prevent you from needing a liver transplant. I don't think it's that powerful, but I think it's one of the key tools that we have, and so it's definitely one that we use.
Okay, thanks. Have you had any word from Dr. Soltis? Do you think he's still?
Okay. I'm going to text him right now.
Okay. If not, I do have a few questions that I can start us off with AIVD and the PFIC-1 complication. But, we can always reschedule or maybe do like some sort of FAQ.
He says, we'll be on in 10.
So we have to banter for 10 minutes.
We have to banter for 10 more minutes. I don't even know what we're going to do.
Okay.
What do you got?
Well, if he's coming on, I'm going to hold the complication questions.
You can ask them and see if we say the same thing, right?
Well, you're being recorded, and we're going to use this later. So I don't know if you want that type of responsibility.
Be used against me.
No, I wouldn't. But I have kind of like a general, just overall, it's kind of a statement slash question that I wanted to end on, but maybe this is a good time to kind of bring it up. So, and this is not specifically transplant. This is just kind of PFIC and kind of a when to talk to your doctor type question. So PFIC itself is somewhat of a silent disease other than the itching and sometimes the jaundice and the bruising at first. And it's not to downplay the itching in the slightest. It's PFIC itself is somewhat of a silent disease once it's managed. But cirrhosis is not a silent disease. And there are certain things that happen in cirrhosis. PFIC leads to cirrhosis. There are certain things that happen in cirrhosis that are a huge cause for concern. But sometimes I feel like as PFIC patients or parents, it's hard to kind of decide, well, when am I overreacting? When is this the time that I need to go? When is this showing progressive signs of my disease? What's just normal PFIC? What's cirrhosis? The two kind of become interchangeable. And I think it's helpful for us to understand, when is it time to, what are those things where we're supposed to be on the phone right away? When are we supposed to go to the ER? What is just basic PFIC? What is signs of cirrhosis? I kind of just wanted to kind of have an open discussion about that, kind of in layman's terms about what some of those things mean, some of those later signs mean, and how we should approach those with our physicians.
No, I think it's a great question, right? And I think, again, this is one of those discussions that extends beyond PFIC.
Right.
Any underlying inherent liver disease that progresses or that isn't, being cured, right? Again, whether it's Alagille's, whether it's primary sclerosing cholangitis, whether it's biliary atresia, these are all diseases where, unfortunately, we don't have great therapies. And so I think a lot of the times, the progression can be variable. And some days you wouldn't even know that this child has a, potentially devastating liver disease. And the question to the cirrhosis is, as we kind of talked about yesterday, right? Most of the complications that are developing are, again, not unique to PFIC. There are definitely PFIC-specific complications. And I think the big ones we talked about yesterday were pruritus, which, in some can be absolutely terrible. Can be just the worst manifestation that's out there. Poor growth, but again, hard to kind of tease out liver disease from, or poor growth in PFIC versus poor growth just in liver disease, because many of our kids with chronic liver disease don't grow well. But most of those manifestations are what we see in any child with liver disease. Whether it's ascites, whether it's jaundice, whether it's, easy bleeding or bruising because of vitamin K deficiency. And so I think the short answer to your question is, and this is what I tell my patients, if there's ever a concern, call, right? If you're ever concerned, you call us, because we want to know everything, because something that you may not think is that important to you, right? Kid's a little bit more tired, he just wanted to sleep all day, and, kind of was acting a little bit foggy. Well, that kid could be encephalopathic with an ammonia of 200, and have brain swelling, but to the parent just seems more tired. Johnny fell over and kind of, fell, looked pretty innocent, but has been kind of, hobbling around for a bit. Well, if they're vitamin D deficient severely, he could have fractured his femur. But in a 2-year-old, you don't sometimes know that. And that's not to scare people, right? But that's just to recognize that, there is no easy answer to the when should I call. And so I lower the bar all the way to the ground, and I say call whenever you think there's a question. There's someone at most of our institutions who's on call 24 hours a day, 7 days a week, who may not know the answer offhand, but can get a hold of somebody who does. And so I think that our job is to be physicians 24 hours a day, 7 days a week. And so I think if there are issues that come up, and you're not quite sure, is this something that I should worry about or not? Call. You call, and you may not get your answer right then and there, but you'll get it at least from our group sooner than later, because that's the expectation. And it's hard, right? Because it's just there's so much that can be complicated by progressive liver disease. It's not just one single thing, and so I think you have to worry about, all these different kind of potential comorbidities that can kind of crop up. But that's, again, not to say that the call is, hey, Johnny fell and, is now limping. It's like, okay, we'll just, give it a day. If he's still limping tomorrow, we'll get an x-ray. I think it's simple things like that. Not everything becomes an emergency, but sometimes it's just that peace of mind to make sure that the family also feels like they're caring the best for their child. And so, I think it's hard to answer specifically, to kind of give, kind of protocol guidelines or have a algorithm that one follows with progressive liver disease. But it is a challenge because there's just so many things that you have to be thinking about, on any given patient. And again, PFIC is one of those where, the rarity of it makes it even that much more complicated.
Okay, thanks for tackling that. I have 2 more specific questions that have come in. So back to the scoring system, particularly the adult scoring system. Is there something within that adult scoring system that gives, say a PFIC patient who's 18 years old and they're in that system, because they have a genetic liver issue, are they given priority over somebody who, say, has alcohol-induced liver cirrhosis?
Yeah, PFIC is not one of those. There are certain conditions, metabolic conditions, like urea cycle defects, maple syrup urine disease, other metabolic conditions whose complications of those diseases can cause elevated ammonia levels because of various other processes, not end-stage liver disease, who they do get priority. PFIC is not one of them. So having PFIC does not in and of itself prioritize you over any other patient with liver disease at this point. It should, but it doesn't.
It sounds like that's something that an advocacy organization could tackle if they raised enough.
Yeah.
Interesting. Okay, that was a great question and a great answer. Thank you. Okay, so and then before we kind of transition on, is there evidence that sodium phenylbutyrate can slow the progression of PFIC2 specifically?
Yeah, so the studies really have been in FIC1 and FIC2. There was a couple case reports early on, and so there was some general excitement about phenylbutyrate and its potential cause, or at least its effect of slowing PFIC or mitigating some of the disease side effects. There was a brief clinical trial that was actually led here by Ben Schneider, who was here and is now in Houston, who's also on the medical board of this organization, where the patient actually looks like they developed kind of an acute liver injury, and the suspicion was that the 4-phenylbutyrate may have been playing a role. He published that in one of our journals, the Journal of Pediatric Gastroenterology and Nutrition. And so kind of because of that, the pendulum kind of slowed everything down, thinking that, maybe that this wasn't going to be the right drug for this right population. I think it's still worth focusing on. I think, like we talked about yesterday, some of these models where we can kind of do cell culture and kind of use drugs in a laboratory to kind of see how they affect the protein and the function of these cells. Is that's what I think needs to happen, which we don't really have yet because of how we talked about yesterday. There's no real good animal models for this. We need a way to study how drugs can affect these conditions, and we don't have it yet. Because again, I know Kyle just joined us, and I want to make sure that he has time. One of the problems is that with drug trials, almost any time, with any drug trial, even without underlying liver disease, there's the potential of liver numbers to go elevated. And liver dysfunction with medications is the leading reason why a drug doesn't get approved. Right? So if you have a drug that you're marketing for congestive heart failure, and you put it into a clinical trial, and you have a bunch of patients who get liver disease elevations,